Hello everyone, this is Dr. Ashley Etchison from the Academy of Online Radiology Education. I work at Baylor College of Medicine in Houston, Texas. This month, we have curated some interesting literature on breast imaging. In this study, authors sought to determine if kinetic parameters from ultrafast and standard dynamic contrast enhanced MRI can differentiate between benign and malignant non-mass enhancement when compared to lesion morphology. 77 consecutive patients with non-mass enhancement underwent breast MRI. Experienced breast radiologists evaluated non-mass enhancement morphology and assigned each lesion a malignancy likelihood score from 0 to 100%. Kinetic parameters were calculated for both ultrafast and standard dynamic contrast enhanced MRI and compared between benign and malignant lesions. Compared to benign lesions, malignant lesions had higher morphologic malignancy likelihood scores. Malignant lesions had statistically significantly higher values compared to benign lesions for the following parameters: rate of signal increase, upper limit of signal intensity, and initial slope of kinetic curve on ultrafast dynamic contrast enhanced MRI. Additionally, signal enhancement ratio and initial enhancement rate on standard dynamic contrast enhanced MRI were significantly greater for malignant lesions. However, there was no statistically significant difference between morphologic score or signal enhancement ratio. The authors concluded that when differentiating between benign and malignant non-mass enhancement, kinetic parameters on dynamic contrast enhanced MRI were as efficacious as morphologic characterization. In this study, authors sought to investigate the relationship between mammographic asymmetry and breast cancer detection at various time intervals. Automated calculations from nearly 80,000 mammographic images were utilized to determine asymmetrical dense volume and breast volume in a large ethnically diverse population of a UK breast cancer screening program. The association between asymmetry measurements and the odds of breast cancer detection on a contemporaneous or same-day screen were calculated using logistic regression models. Additionally, nested case control studies determine the association between breast asymmetries and breast cancer detection at subsequent screenings or in between screenings, which would be considered an interval diagnosis. The authors discovered a positive association between the odds of a contemporaneous breast cancer and asymmetrical dense volume, but not breast volume, with a stronger association for first-time screens. There was a positive association between odds of interval cancer detection and both breast volume and dense volume asymmetry. Neither breast volume nor dense volume asymmetry were associated with increased odds of cancer detection on subsequent screens. The authors concluded that the risk of contemporaneous or interval breast cancer diagnosis is associated with increased dense volume asymmetry. Likewise, interval breast cancer diagnosis is positively associated with breast volume asymmetry. In this study, the authors sought to compare the diagnostic efficiency of contrast-enhanced ultrasound BI-RADS to MRI BI-RADS in diagnosing breast lesions with calcifications. 51 patients were included in the study, and 52 breast lesions with calcifications were detected on ultrasound as hyperechoic foci. Each lesion was assigned a BI-RADS score of 3 through 5 on conventional ultrasound. Patients then underwent contrast-enhanced ultrasound and MRI and received additional BI-RADS scores. Among the three modalities, the authors did not find a statistically significant difference in sensitivity or area under the receiver-operator curve. However, the authors did find that the specificity and accuracy of contrast-enhanced ultrasound BI-RADS were significantly greater compared to ultrasound BI-RADS and MRI BI-RADS. The authors concluded that the use of contrast-enhanced ultrasound BI-RADS increased diagnostic efficacy of breast lesions with calcifications when compared to MRI BI-RADS. In this study, the authors compared the diagnostic efficacy of breast MRI with complete field of view of the axillary region to dedicated axillary MRI in node-positive and node-negative breast cancer cases. The study included 47 patients who underwent both breast MRI and dedicated axillary MRI prior to surgery. Experienced breast radiologists reviewed unenhanced T2-weighted and diffusion-weighted images of both MRI exams. The authors did not find a statistically significant difference in diagnostic performance between breast MRI and dedicated axillary MRI. Furthermore, the authors determined that benign and malignant lymph nodes had similar ADC values on diffusion-weighted imaging on both breast and dedicated axillary MRI exams. The authors concluded that T2-weighted breast MRI with complete field of view of the axillary region is comparable to T2-weighted dedicated axillary MRI when assessing node-positive and node-negative disease. Additionally, the authors discovered that diffusion-weighted imaging and ADC values did not add clinically significant information to differentiate between benign and malignant lymph nodes. In this prospective study, the authors sought to determine the diagnostic utility of bilateral mammography for male patients with unilateral breast complaints. 271 men underwent bilateral mammography and were assigned a modified BI-RADS score from 1 through 5. Experienced breast radiologists performed both unilateral and bilateral reviews of the exams. Contralateral findings and average glandular dose for both breasts were recorded. Breast cancer was diagnosed in 10.7% of male patients with a unilateral breast complaint, and there were no cases of bilateral breast cancer. The authors did not find a statistically significant difference between the diagnostic performance of unilateral and bilateral reviews. The authors concluded that unilateral mammography is as good as bilateral mammography in the diagnosis of breast cancer in males with unilateral breast complaints. In this study, authors sought to investigate the differences in pectoral muscle area values before and after treatment with neoadjuvant chemotherapy. The authors note that quantifying changes in pectoral muscle area is clinically significant, as loss of skeletal muscle mass is a known predictor of toxicity and poor outcomes in breast cancer patients. 110 patients who received pre- and post neoadjuvant chemotherapy MRI exams were included in the study. 2 experienced breast radiologists calculated the pectoral muscle area for both exams. Post-neoadjuvant chemotherapy pectoral muscle area values were significantly lower than pre-neoadjuvant chemotherapy values. The authors did not find a statistically significant difference between non-responders and complete or partial responders per RECIST criteria. Additionally, the authors did not find any significant associations between changes in pectoral muscle area and patients' age, hormone receptor status, histological type and grade, or lymph node status. The authors concluded that pectoral muscle area is significantly decreased in breast cancer patients after receiving neoadjuvant chemotherapy, and that MRI is capable of estimating this metric. For more details, you can read our blog where you can find links to the original publications. Please feel free to share your thoughts and questions with us on the Breast Imaging Forum, and we'll see you next month.